So the next topic by Professor Mehmet Mutlu from Turkey is going to discuss the safety of uterine manipulator during minimally invasive surgery for endometrial cancer. Please, sir.
Good evening to all. Dear chairs, dear colleagues, today I'm going to talk about the safety of uterine manipulator during MIS for endometrial cancer. I have nothing to disclose. I'm going to present you two cases. The first case was a 75 years old lady who underwent robot-assisted laparoscopic hysterectomy and bilateral salpingo-oophorectomy because of endometrial cancer in November 2020. No uterine perforation was recorded during surgery, and the postoperative pathology report revealed stage 1A, grade 1 disease with no lymphovascular space invasion, and no adjuvant treatment was given. In August 2022, this patient admitted with Sabelius, and MR revealed ascites and the 8 centimeter mass on the transverse colon with omental infiltration. She underwent debulking surgery, and the postoperative pathology report revealed recurrent endometrial cancer with peritoneal carcinomatosis. No positive lymph nodes were found, and she received chemo and alive with disease now. This is the gross view of the surgical specimen of those patients. Please remember that she had only grade 1 disease and stage 1A disease, endometrioid type, and this is the macroscopic view of the recurrent endometrial cancer. This is case 2. She was a 65 years old lady. In October 2021, she underwent robot-assisted laparoscopic hysterectomy, bilateral salpingo-oophorectomy, and sentinel lymph node biopsy. No uterine perforation. Postoperative pathology reports revealed stage 1B disease, grade 1. No lymphovascular space invasion. She received brachytherapy. In July 2022, she noticed a mass in the left groin, and in August 2022, she underwent tumor excision, and postoperative pathology report revealed a subcutaneous mass of recurrent endometrial cancer, indicating heterogeneous dissemination. This was not a nodal failure, this was a subcutaneous mass. Why? It has been a matter of debate whether or not the use of uterine manipulator during minimally invasive surgery for endometrial cancer may cause this tumor disruption, resulting in positive peritoneal cytology and presence of lymphovascular space invasion. Uterine manipulators have been utilized during MIS for endometrial and cervical cancer. The LUC trial reported a worse oncological outcome after MIS in early cervical cancer, and one of the hypotheses generated was that the uterine manipulator might influence this worse prognosis. Afterwards, the Sucker study found the use of an intrauterine manipulator was associated with a decreased DFS in cervical cancer patients undergoing MIS. According to an online questionnaire in France, 1/3 of the surgeons have changed their surgical practice for endometrial cancer in parallel after the LUC trial. To date, it remains a controversial conclusion that the theoretical tumor manipulation has no clear impact on survival outcomes in endometrial cancer. However, the ESCO recommendations published in 2021 recommend the use of MIS when surgery is considered in the management of endometrial cancer while avoiding tumor spill. There are 9 studies in the literature suggesting that uterine manipulator increases the rate of lymphovascular space invasion, positive peritoneal cytology, and or free floaters. What are free floaters? Free floaters are free-floating tumor fragments within the lumina of the fallopian tubes, and these have been found to be associated particularly with robot-assisted laparoscopic hysterectomy. However, there are 9 studies in the literature indicating that uterine manipulator does not increase the rate of lymphovascular space invasion and or positive peritoneal cytology. There are 8 studies in the literature suggesting that uterine manipulator use is not associated with poorer survival outcomes compared to no uterine manipulator use. However, I want you to pay attention that in 3 of those studies, there was a trend towards worse oncological outcomes not reaching statistical significance. And one of those trials was the randomized controlled trial, the Romani trial. And there are 2 studies in the literature suggesting that uterine manipulator use is associated with poorer survival outcomes. What is the reason for the discrepancy in those studies? When the magnitude of the differences to test is low, large sample size are required to detect statistical significance. When the low risk of recurrence in low-risk endometrial cancer, that's less than 3%, is taken into account, larger sample sizes are mandatory to detect significant differences. The Romani trial is the only randomized trial on uterine manipulator use to date. 154 patients were included. The Romani trial did not show a negative effect of uterine manipulator use on survival outcomes. However, the lack of the power of the trial did not allow the question to be answered. What is the current surgical practice in the United States? In a survey of 220 gynecologic oncologists practicing MIS for endometrial cancer, 90% used intrauterine manipulator, 87% have experienced uterine perforation, 96% performed colpotomy laparoscopically, and 60% had experienced tumor spill while making colpotomy. I want you to pay your attention that only 14% ablated or ligated fallopian tubes prior to performing hysterectomy. What is the current surgical practice in France? The routine use of uterine manipulator for minimally invasive hysterectomy for endometrial cancer was 42%, and uterine manipulator was set up without laparoscopic control in 55% of the cases. And again, pay attention that tubal obliteration at the beginning of the procedure was performed systematically in only 35% of the cases. From a national cancer database analysis, approximately 75,000 women with FIGO stage 1 endometrial cancer who underwent simple hysterectomy were included, and MIS was compared to open procedure. A higher proportion of the patients who underwent MIS had positive peritoneal cytology and presence of lymphovascular space invasion. After controlling for tumor size, tumor grade, disease substage, and MIS was associated with higher odds of positive peritoneal cytology with the odds ratio of 2 and presence of lymphovascular space invasion with the odds ratio of 1.3. And this was the largest study, although retrospective to date. This is a prospective multi-center single-arm study which was published in September 2022. The primary objective was to assess the rate of peritoneal cytology becoming positive during the course of surgery. And for that reason, the authors obtained pre-manipulator washings. Then they coagulated the fallopian tubes bilaterally before the insertion of the uterine manipulator, and then they obtained post-manipulator washings and finally post-hysterectomy washings. Let's forget about group 1. They had negative peritoneal cytology. Group 2 included patients with positive peritoneal cytology. This was 26 patients. And let's also forget about group 2A with the patients with positive pre-manipulator washing. We should focus on group 2B, including 10 patients. Those had negative pre-manipulator washing becoming positive during the course of surgery. 2 of them had positive post-manipulator washing, and 8 of them had positive post-hysterectomy washing. What about the recurrence-free survival? The median recurrence-free survival of the patients with converted cytologies was the worst, and this indicated statistical significance. Also, the recurrence rates indicated statistical significance within the groups. The worst recurrence rate belonged to group 2B with the patients with converted cytologies. What about overall survival? There was no significant difference between the 3 groups in terms of overall survival. This study demonstrated positive peritoneal cytology conversion in 8% of the patients with endometrial cancer undergoing MIS with intrauterine manipulation. And on multivariate analysis, positive peritoneal cytology remained as a significant independent predictor of risk of recurrence and death. And this is the largest study, although retrospective to date. This was a multi-center study coming from Spain to assess the oncological safety of uterine manipulator in women with apparent early-stage endometrial cancer treated with MIS. There were 1,756 patients undergoing surgery with uterine manipulator. Those had a recurrence rate of 11.7%, and there were 905 patients undergoing surgery without uterine manipulator with a recurrence rate of 7.4%, indicating statistical significance. The disease-free survival of the patients with no uterine manipulator was statistically better than the uterine manipulator used group. Whereas for FIGO stage 3 patients, there was no difference in terms of disease-free survival. In terms of overall survival for FIGO stage 1 and 2 disease, no uterine manipulator used group was better than the uterine manipulator used group. The use of uterine manipulator was associated with a higher risk of recurrence, and the most common recurrence patterns included peritoneal carcinomatosis and visceral metastasis. The use of uterine manipulator in FIGO stage 1-2 disease was associated with poorer DFS and higher risk of death. What are the possible probable mechanisms of tumor spill? Weakening of the uterine wall and accidental uterine rupture, tumor manipulation during insertion and colpotomy, lymphovascular space invasion, tumor dissemination through the fallopian tubes, and the most important one is the effect of pneumoperitoneum. And this is the most recent systematic review about this issue, which was published in the American Journal of Obstetrics and Gynecology in September 2023. There were only 14 studies included in the final analysis. I want you to pay attention to the number of the patients, 42 versus 42, 46 versus 46, 55 versus 55, and such goes on, 13 versus 13, and the number of the cases seems not to be enough. What about the characteristics of the included studies? Retrospective. This is the largest study coming from Spain. This is the randomized controlled trial from Italy. Only 156 patients were included. And what about the oncologic outcomes? The median follow-up of the patients doesn't seem to be enough for drawing a definitive conclusion. What about the results of the conclusion of this meta-analysis? Few studies have assessed the effects of intrauterine manipulators on oncological outcomes. From this study, the authors reported that intrauterine manipulation during hysterectomy was not significantly associated with recurrence-free or overall survival. However, pooled hazard ratios for recurrence impede excluding an association. What does this add to what is known? Pooling available evidence, intrauterine manipulators remain potentially associated with endometrial cancer recurrence. Given that their use is not mandatory, even minor increases in recurrence risk can be questioned. Therefore, further investigations on oncologic outcomes instead of pathologic characteristics are recommended. Thank you for your attention.